This webinar is titled Health Managers and Leaders, Harnessing the Power of Digital Technologies. And it's episode 1 of the webinar series called Health Management in Action, Fostering Health System Resilience. And we're really grateful to the European Commission, the EU for Health Programme, who are co-funding this initiative. I'm George Valiotis. I'll be facilitating today's session, and I'm the Executive Director at EMA. So a little bit about EMA before we get started. Our vision is excellent health management for a healthy Europe. And we achieve this vision through our mission, which is to support the spread of knowledge on effective health management, much like we're doing in this webinar today. And we use our values in everything we do, which is excellence, quality, inclusiveness, relevance, and respect. Also, we are uniquely the only membership organisation in Europe to bring together the full diversity of health management ecosystem. We're a recognised and respected amplifier of best practices in the evolution of health management. And we like to provide an environment where evidence, challenge and experience are valued and complex debates on current topics can take place, again, which we hope to see happening today. So we really welcome your engagement today. So a little bit about this series. Our series, Health Management in Action, Fostering Health System Resilience, is discussing health management topics that are crucial to improve health system preparedness and response. And I've mentioned that it's co-funded by the European Commission. And what I want to do today in our agenda today, we're doing really well for time. Immediately following this introduction, we're going to hear from 2 speakers. And the first one's going to look at health management and digital technologies, which will be presented by Dr. Alexander Lorenzo. And then directly after that will be our next speaker, who's going to look at actual practical case studies on digital technology applications. And that'll be presented by Mr. Pedro Ramos. So we've got about 30 minutes to start off with, and then we'll have Q&A. And in that Q&A, we really encourage you to engage and get your questions answered. These webinars are designed to be bite-sized, and they're here for you to answer your questions. So feel free in the chat box to type your questions in, and then afterwards in the Q&A, we can also speak live. We've muted everyone's microphones just to keep the flow clear. And as I said, you can put your questions in the chat box. Of course, we're recording the materials, and we'll also do a summary report, which will all be available on our website. And finally, of course, we're live tweeting. If you're not already following us, make sure you grab Twitter and find us on @EMAInfo. And please use the hashtag #EMAWebinars to discuss today's topic. So to tell you a bit about our speakers today, we're really honoured to have Dr. Alexandre Lorenzo, who's a health administrator at Coimbra Hospital and University Centre in Portugal, and also Mr. Pedro Ramos, who's a member of the Board of Directors of Promptly Health in Portugal. I thank you both for joining us. And without further ado, let's move right ahead and start with Dr. Alexander Lorenzo. Welcome, Alexandre. Thanks for joining us.
Oh, thank you, George. It's a pleasure to be within this webinar series, and it's really an honor to be participating in the first of this, I'm sure, amazing series of webinars. Mostly, I will talk a little bit about health management and digital technologies, but I will firstly start with the influence of digital technologies in healthcare, and then I will move for more practical approaches where digital technologies are changing the way that we manage hospitals and other healthcare providers. Let me just start with this perspective from the health system panorama. And I believe that mostly the health system is typically dominated by traditional providers. And when I talk about traditional providers, these legacy providers, mostly we are talking about hospitals, primary care centers, clinics, etc. And of course, we continue to have a big influence from the pharma and medical devices industry. These two have been evolving together in developing precision medicine and risk-sharing contracts. Actually, even the European Commission and EMA recently, for example, one of the examples of these partnerships started the Eden project, where even Pedro can talk a little bit about it. Mostly this possibility to measure real-world data that will allow us to have a better analysis of the products and services that we are a provider, that will influence, of course, also the introduction and evaluation of medicines and medical devices. But also hospitals understood for the last years that they need to break their walls, and they are increasing what we would say the proximity of services to patients and to communities, namely to solve problems in provider-patient transitions, where we have several gaps and practical issues that are not addressed. I must say, for example, in my hospital, we are quite engaged in telemedicine. We started telemedicine in 1998, at the end of the last century, and mostly to support developing countries or low-income countries in Portuguese-speaking countries, but also across the country. And we have a spread telemedicine through different medical specialties. But for example, another project, a recent project that we are engaged, that is pre-commercial procurement, also funded by the European Commission, that is ROSIA, that is aimed to provide rehabilitation to remote rehabilitations for patients that live in rural areas. And you can get more information about this in rosia-pcp.eu. That is a very, very big project that we are committed with other European partners. But also, of course, we are also committed in home hospitalization and remote monitorization of patients, of course, hospitalized at home, but also chronic patients like COPD patients or cardiac insufficiency patients. But this is the idea that mostly hospitals are moving outside of their walls. And more than that, we must say that even within this context, a third party of providers are emerging. Primarily, they are technological partners that work with legacy providers and pharma and medical devices industry. Even though these new providers, these digital providers, they are influencing the way that we provide care, mostly influencing with big data, remote monitoring, etc. And even though they still rely on conventional providers, they now venture themselves to solo initiatives that are mostly disruptive, like remote physical therapy, teleconsultations, that really are disrupting the way that the conventional legacy providers provide care. And in my opinion, we also start to have a new sort of providers that are, we would call an alternative providers, that are also emerging, that are individual health providers. And this mostly is bring by digital or technological companies that are investing in health promotion and disease prevention. And mostly they are able and have the capacity and resources to influence all the healthcare system as we see it right now. And they are influenced and they will influence the way that we provide care. So this is probably in the next few years, we are going to see much more influence, but by these individual health providers, that mostly these actors are big tech. Let me go a little bit more focused in the influence that digital technologies are influencing operational decision-making in hospitals, and how this digital transformation is influencing the way that we provide care. The first idea that I would like to bring is this idea, the influence that data is influencing the way that we assure and that we manage patient flow in the healthcare providers, and now this data-driven operational decision support can provide valuable insights to aid in making things like triage, admission, and discharge decisions. There are several hospitals, for example, that on ER, they are providing algorithms that predict hospitalization with the data from the initial triage that allow the hospital to immediately reserve an hospital bed. And if it's not available, that bed, it will allow also to early to prepare a discharge to provide that bed for that patient. So these decision support algorithms, mostly using machine learning, are influencing the way that we manage patient flows within hospitals, as an example. Another component is staffing, and digital technologies can also help with the supply side when it comes to better managing capacity. And I imagine, although most of our countries, we have problems in staffing for emergency rooms, and actually these algorithms can predict, for example, nurse absenteeism rates and the need for surge staffing preemptively, and to determine the right number of float nurses to call in. And this is quite relevant and to support hospitals in staffing. Another area is scheduling. While most of the hospitals still rely in manual scheduling, the fact is that machine learning algorithms can also help us to predict the duration of each procedure, such as the length of a surgery, and optimizing, for example, the scheduling of surgery, optimizing the utilization of operating rooms, or even automatically schedule outpatient appointments according to the specificity of the medical care that is needed, allowing us to have a better utilization of our resources. Another component is the influence, of course, in supply chain management. And across many industries, the digitally transforming the supply chain has been able to reduce costs and increase revenues. And of course, hospitals are not the exception. And by automating processes of collecting data, ordering, reconciling, and paying medical, surgical, and pharmaceutical supplies, hospitals really can reduce supply chain and inventory management related costs. And here different hospitals are using radio frequency identification technologies and more advanced logistics systems that allow us to have a better management and a real-time management of supplies that allow better uses of equipment and consumables. To finalize, let me talk a little bit about how technology can help supporting better participation for healthcare reframing. And this is an introductory note for the work that we are doing in our hospital with Promptly that Pedro will present. I really believe that the digital transformation is supporting, as it was never been able to be accessible before, to engage patients, not only in the way that traditionally we were measuring PROMs and PREMs, but allowing us to really have the data and allow us to use that data to change the way that we provide care. And this is only possible due to digital transformation that makes it much more easy, much more feasible to engage patients and use the information of the patients, allowing us to provide better care by managing better health services. Thank you so much. I'm open to any questions, and I believe that I give the floor to George or Pedro.
Yeah, thank you very much. That was a really interesting presentation, Alexandre. I appreciate it. And we are really encourage questions from the audience. We'll go on to Pedro next, and then we'll take the questions all together. But do take this moment if you want to reflect on any of your questions to start to type them in the chat or keep them in your mind. And also mention, just before we move on, Alexandre, can you tell us again the link about Promptly so that people can look it up?
Pedro can...
I can type it here.
Yeah.
Oh, great.
Perfect.
Wonderful. Thank you very much. So Pedro, over to you, and then we're doing really well for time. So
yeah, okay. So I don't have to speed it up. So yeah, I second Alexandre saying that it's an honor and a privilege to be here speaking about this topic and the work that was started with Shook and by Shook a few years ago. I don't want to scare anyone about the time that these things take, but this is a journey that started in 2018. Everyone is seeing the slides, right? So a big Earth image, and I chose to start this conversation with this because I think that 9 out of 10 conversations about data and healthcare and so on and nowadays eventually end up with this, like saying that nowadays 30%, a big part of the world's healthcare data is generated in healthcare, and that is the new gold, and that's a bit of the representation why we put that in a goldish color. But I would start to dispute that by asking if we can call something data if it's not efficiently able to be processed, to be stored, and to be analyzed in a way that is actionable in a reasonable amount of time. And it sometimes seems a bit dystopian world when we at the same time read this, right? So this is a new from a bit before the pandemic, but it's 2019, and it says that 9 in 10 in healthcare industry is still using fax machines. I was actually a bit shocked a few months ago when I heard from someone that in 2 of the largest healthcare countries, 2 of the largest European countries and richest countries in Europe, the last or one of the last fax machines were being disabled. So I don't think I don't remember if I have ever seen a fax machine working. But sometimes it's a bit dystopian if we think that, okay, we say that there's data and so on, but then this is the reality. And there are so many healthcare managers in the room, so I think everyone believes and thinks that in a way this is the reality right now of healthcare, is that each hospital, each health system has data or information, if we want to call it that, regarding care, regarding pharma administered, sometimes about outcomes, imagology or lab results, and each one has this in their own silo, so a lot of data isolation, and that's represented a bit by these 3 different boxes, and also data. Even if we could integrate all of this data, the data is not harmonized. So oranges are not oranges, apples are not apples. So we talk about even like the simplest concepts, or the concepts that should be simplest, like what was the drug that was administered, what was the compound, and between hospitals, sometimes even within the same country, this concept is not understood the same way and this data is not harmonized in the same way. Obviously, how we strive for and how or what we think the healthcare industry should look like is that, well, the world tomorrow should be that, well, even if we would have this common data model where the concepts would mean the same and data could be more easily analyzed. And these two challenges were like data isolation and data harmonization were the two challenges that were tackled back in 2017 when the hospital started looking at this in these two different initiatives that started, one before and then one afterwards. One was to create this network, real-world evidence network that could generate data on specific areas, and the other is an European project, data harmonization, an European project that Shuk has also now engaged on. And I'll speak about these two very quickly in the next slides. The first step of moving into these two projects or into these areas was to standardize this data journey. So really understanding how to get to 4. So in the 4 real-world insights, understanding the disease, really unlocking all the benefits that Alexandre talked about before. And I think everyone understands those and quickly speaks about those and sees the value of those. But sometimes steps number 1, 2, 3, especially number 1 and 2, are undervalued, I would say, or the effort that it takes is severely underappreciated. And to really get to that first slide, that is, okay, we have 30% of the data that is generated in healthcare, and that is gold, and we can create value out of that data. This process needs to go quickly or needs to be scalable. But for that to happen, these 4 steps, or each one of these steps, needs to be standardized in terms of processes, in terms of platforms, and I mean, in many countries, but certainly in Portugal, all the hospitals have their own platforms. We are fortunate enough, we are happy enough to have common, what could be called a common electronic medical record. So there are infrastructures already on the ground, but still these four steps need to be clearly standardized, need to be, in our view, need to be clearly standardized to understand how you can get from 1 to 4. And by doing those, the first program that was created was this real-world evidence network. So the hospital, in this case Shuk, captained the first evidence, or one of the first evidences network in with patient-reported outcomes, and in this area in Portugal. It involves 16 hospitals or something like that. And the 3 key benefits, and after 4 or 5 years, the 3 key benefits that the professionals and the hospitals, people and stakeholders mention is these 3 on the right. So one is actually being able to take insights out of the data that is collected and harmonized, and understanding, for instance, why do 10% of the patients have lower visual function after surgery? So why, who are these patients? What are their comorbidities? What is happening with them? And even understanding if they would need surgery in the first place. And that's potentially a new or a very important definition of waste. The second one, and for a country like Portugal, I think this is very important. So creating more capabilities for large-scale clinical research, and especially the ones with real-world data, with the data that is already on the clinical records. So as I mentioned, the country has an EMR, a centralized EMR, and has infrastructure that could allow for these networks to happen, and for these real-world evidence studies to materialize and to scale. And then the third one, and considering that many of the hospitals in the network and especially Shuk is a very strong academic hospital, creating a culture of education over the data, namely through subset analysis of the outcomes by residents, engaging the residents into discussing the patient outcomes and making publications even out of those outcomes, using that data for their final certification when they apply to their title for their specialist program. It was partially due to some of these benefits that the program was recognized by the World Economic Forum a few years ago, and it's now scaling to other diseases, to other areas, by these hospitals, so by the public hospitals and the private group themselves. If you in the audience are thinking a little bit about, well, but how could we start this journey, and how could we have even the funds to start this journey and to have the support for starting this journey? There is a new program there's a program in the European Commission that is called EVEN. It's an ongoing program. That is the largest data harmonization program nowadays in Europe. It's very much aligned with this data harmonization and real-world interrogation network that is being created by the European Medicines Agency called Darwin, and it's a first step for health systems, for large hospitals in Europe, to start having their data harmonized, and start and materializing that world of tomorrow that was in one of the initial slides. Nowadays there are several large organizations, large hospitals, and also large pharma that is involved in this program. It's an European Commission program, which has dedicated funds for the hospitals to do this work. So I strongly encourage health managers and hospitals in the audience to have a look at this and see if this is something that could help start this journey or help in their own journeys in this area. And this is a program that Shuk is now also one of the representatives in Portugal. And I end up with this slide. This is, I'd say, motto or an ambition from the European Medicines Agency for this Darwin network. That is, by 2025, the use of real-world evidence will have been enabled, and the value will have been established across the spectrum of regulatory use cases. It seems very, very ambitious, especially considering the timeline. Obviously, it's clearly in the right direction, but our views is that if these processes that I mentioned before, that are part of the learnings of these projects, are not carefully addressed, this vision will be difficult to materialize. But certainly, it's in the right direction. And yeah, thank you. And I move on also to questions from the audience.
Terrific. Thanks very much, Pedro. That was a very insightful presentation, and we will now move to questions from the audience. There's already one in the chat box, and what we can do is you can either type your question in the chat box, or you can also put your hand up, and we will activate your microphone and camera, and you can ask it directly. So I'm going to start with the question from Katarzyna. Katarzyna, if you don't mind, we'll just activate your microphone and camera, and you can ask that directly. So that should be getting done in the background. There you are.
I think I've done it myself.
Oh, good, good.
Hi, hello. Thank you for a very interesting presentation. I was wondering, a lot of topics in Poland are related to paying for performance, also for hospital care. We do not have such kind of data. We are yet working on that. But in Portugal, do you have some initiatives to actually include the indicators on the outcomes in some kind of pay-for-performance schemes for the providers?
Yes, I can talk about our primary care. We have several pay-for-performance incentives, mostly related with, for example, chronic diseases management, like the percentage of diabetics that are controlled, or cardiac insufficiency patients, or hypertensive patients. But also at the hospital sector, we started in 2007 to apply bundle payments. Firstly, in HIV and hemodialysis, and then we moved for cancer, mostly breast cancer, cervix cancer, colorectal cancer, lung cancer. So bundle payments. What we have done during this period is to start to measure indicators that would allow the pay for performance, even though they are not in place at this moment. I must say that even the Portuguese Association of Hospital Administrators and the Institute of Oncology of Porto, they develop what we call a value-based project for lung cancer, where we measure, both of course we did the costing for treating lung cancer, but also the measurement of PROMs crossing the process, and we are trying to influence the Portuguese payer to adopt that model for pay for performance. But at the hospital level, pay for performance is very limited to some efficiency indicators or even readmission indicators, and not to specific indicators like would like to be like a clinical, specific clinical quality or patient experience.
Okay, thank you.
Alexandre, you mentioned several different types of diseases, and one of the things that I was noting, of course, there's the topic of privacy and patients' privacy, and across different disease groups, we see different expectations from patients. And one of the ones you mentioned was HIV, which has been a very good learning for us as a system about people not wanting their records shared across different providers. How has that come up and been factored in some of these projects?
Actually, well, we are all obliged to all the data regulations that we have in place in Europe. At some point, for research purposes, it began to be a limitation. But anyway, we need to deal with it. It is relevant. And when I say limitation, is that mostly to cross data across different databases. But anyway, we have this. These characteristics, and we need to deal with it. But I don't see that is a big problem for this kind of issues. Even the programs that we started in 2007 for HIV, for bundle payments for HIV patients, even back then anonymity wasn't an issue. It was from the start as assured.
Okay, that's encouraging. I see also there's a question from Renato that he's typed into the chat box. Renato, would you be happy to speak to your question? I see his camera on and off, so maybe now he's... I'll go to your question, Renato, if you can hear us. I'll just read it out. You said you really like the presentations about the possibility to optimize health management through machine learning algorithms. However, as a physician in Portugal, you believe that the input to most of this algorithm is compromised due to the absence of clinical leaders in digital transformation projects. And as a result, we can improve management in several areas, but I think it does not imply an improvement in clinical care. And the question goes on. I wonder, Pedro.
Sorry.
Renato, hello, welcome.
Sorry, I'm here. Sorry.
I've been reading out half of your question.
Yeah, it's easier for me to explain. I think it's related with what Dr. Alexandre just talked, is the use of several databases that we need to make input so that we have accurate information. And most of electronic health registrations, we are not doing that as a clinician. We usually don't do it in a structured format, which I think will imply in the quality of the results of most of these algorithms. I think I would like to know how can we change these, the way how health care workers can all of them work for this purpose, because using several databases and using most of the clinical care without being in structured format, I think that might compromise the use of these algorithms. That's all.
Pedro?
Yeah, I totally agree. So I totally agree that clinicians and all healthcare professionals need to be at the forefront of these programs, and it is the case in the program that we presented. But like the champion is a clinician. All the hospitals include the champions are clinicians, are the department heads, but also then the right hands of the department heads or clinical managers. So I think that's one of the reasons why the program was able to be sustained, to continue, and to grow also in terms of the data. So I totally agree that this is needed, and I totally agree that it is less the case in many of the programs, and that's one of the reasons why some of these don't produce good results or don't produce actionable algorithms or programs or data. So that's true.
I just continuing on Pedro, I really, this is a health management issue. That is the engagement of healthcare workers on all this change managing process. Anyway, let me just say that it's important to, most of our focus in the digital transformation is on the power of data to on clinical decision making, and it's mostly focusing on clinical decision. And of course, health management has a role on it, mostly on team management, change management, all of that. But again, I really believe that at some point we are missing the digital transformation. I wanted to convey that we are missing the role of digital transformation in optimizing operational decision making within healthcare providers. And we really need to focus more on the topics, on the role, of course, of machine learning algorithms and other solutions, RFID, whatever, in having more efficiency in our operational decisions. So it's not only a matter to promote clinical decision, it's also a matter to promote management decisions and better management decisions within our organizations.
Can I ask Pedro a question, George?
Yes, in fact, Annalise, I was going to come to you next, but I'll just
okay, thank you.
Renato, just to see. Renato, was that sufficient for you? Because it looked like you had something else you wanted to add.
No, I agree with what you talked about. I think the focus is right on this, using the algorithms, but for the clinical purpose.
Great, terrific.
Thank you.
Great. In that case, Annalise, I'll hand over to you.
Yeah, we were talking about outcome of care. And what I was wondering is, Archam has done a lot of work. Have you looked at Archam to help you measure outcome? And we're in an age of value-based healthcare, where the patient role is also a point. but when we talk about outcome, do you take the patient's opinion of his own quality of life, of quality of existence into consideration when you measure outcome? Have you done that?
Yeah, so that's a nice question. So the 2 points, so starting by the second one, yes. So one of the results that I mentioned is exactly on patient-reported outcomes, and I think the interesting part as well is understanding the difference between patient-reported outcomes and even clinical outcomes, because measuring success by clinical outcomes like visual acuity, that was one of the metrics, was not entirely correlated with the actual patient ability to function and to have visual function, so to read newspapers and things like that. So so yeah, that's totally needed in these data initiatives, is to also start including patient-reported outcomes, patient-reported experience measurements, although it is hard, and this was in a clinical area that is particularly hard. The average age of patients that have surgery at CHUK in ophthalmology is 72, something like that.
Can I add something to my question?
Yeah, sure.
Yeah. Sure. I'm also talking about joint decision making and decision making about the patient's own care process, and helping patients to decide on what they want to do, what is relevant for them. And it might not be relevant for a doctor, but might be relevant for a patient to do or not to do anything, whatever it is, whatever the choice is. But joint decision making this person, then measuring the outcome for the patient in that respect. That is what I'm interested in. And you talk as though you've done a lot in that direction. I would be interested in how you did it also. But the first question, the question that I add is, have you looked at joint decision making about a healthcare plan, a treatment plan? And have you measured outcome regarding the patient's goals?
Yeah, so patient-reported outcomes and experience measurements are super interesting tools for that. The challenge, and although I don't want to over focus the challenge, but the challenge is that you need to have this scalable, so that you can bring these results, you can bring this data when the moment is needed. That is when the doctor and the patient are in front of each other, and this can be for care plan discussions, as you have mentioned, for chronic disease, for oncology, that was mentioned by Alexandre, but even for surgery, for surgical procedures. So I think it's astonishing and interesting to understand that there are some patients that don't improve with the treatment. Actually, the patient-reported outcome that was used in Portugal was used in Sweden by the Swedish registry to do this kind of shared decision making, where they had some kind of an algorithm where they would predict or understand the probability of that surgery for that patient get an improvement and get a result, and with that result it could be discussed with the patient before the surgery. It's complex. I think these are complex changes. It involves many things, but it's a journey at the same time. And you need the infrastructure, the processes, the clinical leadership to do this, and the time to mature, and the persistence. And I think there's this webinar series about resilience. It's important that these journeys and these projects have the resilience to go from to increasingly have new positive parts. So it's the way that I see it, and I think that has been the experience in Portugal for this.
Thanks.
Yeah, this I don't know, George, if I can come in. Mostly this project that Pedro was talking about, it's a joint project between private and public hospitals in Portugal. We in the first year we gathered more than 10,000 patients, where we can benchmark different hospitals according to the results that they have, and this is only the benchmark. Also allow us to find ways of improvement. The data is public at this moment, and anyone can consult the overall results. But I believe that this is an amazing power to mostly to change the way that we provide care. This project was very specific for cataract surgery. Of course, we are moving to other conditions. For example, we have a very big European project on stroke currently that creates new venues of problems, because even if this one in cataract surgery, of course, vision is an issue, and even the age of the patient is an issue. Also, a stroke creates this kind of new challenges, mostly because, as you know, hospitals provide acute care and not the rehabilitation. So it creates also different challenges that we need to make. But I believe that, of course, these are tools that will allow us to improve, but by engaging patients within these projects. And I totally believe that, of course, we need the clinical leadership in each clinical area to lead these projects. And of course, the health managers that will promote these changes and create the ecosystem to enable this clinical leadership within our organizations.
Great, thanks, Alexandre. We're out of time. There is one more question I do want to come to, and from Sandra. And just before I come to that, what I will say is we're going to put a link into the chat right now for an evaluation. It's a genuine 90-second evaluation, and it's really important that we get your answers to that, because in fact, it's the evaluations with the feedback from our members that help us design these. And we want them to be for you. So the more you can tell us in those, the better. It'll take you 90 seconds. It's taken me longer to describe it than it'll take you to fill it out. So please do that. And while you do that, I'll hand over to Sandra for your question.
Hi everyone. Apologies for actually linking in late, but I got the gist of this very interesting webinar. Recently, I attended a session on blockchain technology, and they were actually talking a great deal on blockchain technology application in healthcare, in view of issues that we have been talking about regarding the complexity of healthcare, the massive database of patients' records, privacy, protection, and handling. What is your opinion on this? Basically, is it something worth in the future looking into, or is it hype? I mean, we actually listen a great deal on crypto, right? And investing on the cryptos. It's about blockchain. I would really like sort of if there are any people in the audience. I've received a message from Arthur, actually, who has directed me to look at one website. But
if we could maybe answer that, if people could just very quickly, maybe if Alexandre and Pedro, if you had a very quick answer for that, so we can wrap up.
This one, first of all, it's good to see our president, Sandra. Thank you so much. It's really, really great. And I'm an ignorant, completely ignorant on it, so I moved to Pedro.
Well, I think that the Eden project goes in the direction of decentralized data analysis. Even if you don't use a blockchain or something like that, I think decentralization of data analysis, the data staying at the data owners, patients, ideally patients and the clinical data at the hospital's premises. It's something that is the correct way to go for the future. But to be honest, if we were to do that nowadays, it would stop clinical research. It would stop so many initiatives that we have right now, especially because of the challenges that I mentioned in the beginning. So that's why data harmonization, data interoperability is needed. So that's my view and my take on it. So I think data decentralization is a future, but there are these challenges that we need to tackle.
Thank you for your challenging question, Sandra. It looks like there's more for us to think and do about that. Arthur, I see you have a question. We are really out of time. So if it's a 3-second question, go ahead.
It's only the statement, what is just done, is not correct, because the volume of data is much larger than any hospital can build on and grow on it. That's one of the biggest issues that nobody recognizes on momentary in the healthcare. So we trying to solve that problem. Just that's just maybe another time that we can explain what is happening in the next couple of decades, and that is more than everybody thinks on this moment in Europe. And that's the point. That's only the complete gene. We do the complete genome in our format box. That's for important. We built a biometric passport on it, and you see the volume of data is huge.
Great, thank you for adding that. Pedro and Alexandre, I really want to thank you for your great presentations. You've clearly given us a really great view into some of the things to consider and some approaches that are being used. And you've opened up the box to get some great discussion happening. You can see we've gone over time with questions because of that. And I mean, I have 100 more questions about training, about environmental protection, and more. So we can all have more discussion in the informal chat that we can do after this session closes. But just for formalities, I want to thank you all again. I want to thank you for participating. I also want to thank the Commission who are co-funding this series, and I really encourage you to stay involved with us. I know a lot of you here are already members. If you're not a member already, then please get in touch with us so you can become an official part of this health management movement that we have. And it'd be great to see you joining us in the future meetings. So thanks again to everyone, and we'll hope to see you soon.